All right, perfect. Well, thanks everyone for joining us this morning. I have the pleasure of having two esteemed colleagues of mine here on this panel. I'm Shana Hoffman, President and CEO at Lucet. We are a behavioral health optimization company that works with health plans to get members directed quickly to high quality care. I am joined by Wendy Zhao, who's the Associate General Manager, Associate?
Either works.
of Market Development and Performance at Scan Health Plan based in California. And then Samantha Chafin, who's the Senior Director of Behavioral Health Strategy and Operational Integration at Florida Blue. So before we get started, I'm just going to pass it to each of you if you can just share a little bit about your background and your role at your respective organizations.
Sure. Well, thank you everybody for coming. It's great to see everybody here. Thanks for the introduction. Wendy Zhao, so as Shana mentioned, General Manager for Scan Health Plan. I cover our emerging markets of Arizona, Nevada, and Texas. Really excited to be here, about the behavioral health challenges that we face at a health plan that's focused on Medicare Advantage. I've spent my time in my career at various financial and operational roles within the healthcare ecosystem. But at SCAN, especially coming out of the pandemic, we kind of took a hard look last year about what are we doing to really service seniors around behavioral health and what can we do better. So really excited to be sharing more about that with you today.
And hi again, Samantha Chafin, and I work at Florida Blue, which is the Blue Cross Blue Shield plan in the state of Florida. And I have to confess, I stopped counting at 30 years when I realized how long I've been working in the health plan industry. But the last few years have been very exciting. So my responsibility is to work with our leadership at Florida Blue and infuse into everything we do across the enterprise mental well-being. And so it's been an exciting journey for the last 3 years as we have evolved, expanded our solutions and our services to address those needs of our members and to drive outcomes that ensure our plans are affordable. So that's really where, particularly as we talk today, the work we're doing with Lucet has enabled us to do that.
Great. Well, thank you both of you for that. Maybe we can just start broad and you can talk for each of your respective organizations sort of what mental health means to you and looks like and sort of the value drivers. And maybe let's start on the Medicare side with you, Wendy.
Sounds good. So for those who don't know, SCAN stands for Senior Care Action Network. We're a Medicare Advantage focused company, not-for-profit, founded by seniors back in 1977. So we've been doing MA for many decades. So our focus is around seniors, older adults. And, as I mentioned, coming out of the pandemic, there was a lot of, social isolation, just a lot of kind of triggering moments for older adults as to why they needed more support in behavioral health. And so when we think about, what we're doing in the space, again, we took a hard look last year and thought, we can service our seniors better. And for me, a lot of the purpose in what I do comes from my own personal experience and the challenges I faced with my family in ensuring that they're accessing the right level of care when they need it. So for today, I'm just going to choose one example about why I'm so passionate about what we're doing at SCAN in behavioral health and what we're really excited to be testing with Lucet. About a decade ago, my grandfather, he's been in the United States for a long time. He was living in San Diego with my grandmother, really happy, healthy, lively, but he had another family back in China. It was a family before he met my grandmother, and we had found out that his only biological son had passed away in a car accident. And within a few months, he completely lost his will to live, and we had to transition him into a nursing home. And we made the really tough decision to feed him through a tube, defecate through a tube. And sadly, he ended up laying in a bed in a nursing home for 2 years until he passed away. The point of me sharing this story is, now that I've done therapy myself, I've kind of gone through my own journey, I think back to, I wish I could turn back the clock and talk to him and ask him, what happened, right? Or were you really depressed? Did you feel guilty because you were so far away? Did you not feel comfortable talking to us, your other family? I don't know. But I think the point of this is behavioral health is completely interconnected to physical health. I think we all have examples of that. We all have seen examples of folks who struggle with substance abuse who end up in the emergency room, right? So it's completely interconnected. And for Medicare Advantage, which is government-funded insurance for seniors 65 and up, we have to think about this holistically, right? Because our goal at SCAN is not only to give seniors a happy and healthy and independent life, but we also want to provide cost savings to the government, right, as a government-funded insurance. So when we think about behavioral health, we want to incorporate it into the holistic thinking and how we've structured programs at SCAN, especially in the last year as we've implemented Lucet, is what I'm really excited to be sharing a little bit more about through the panel today.
Great.
Yeah, and Wendy, thanks for sharing that personal story. It's interesting that when I think just a couple of decades ago that my own family encountered challenges with family members who were suicidal, but we didn't talk about it. It was unmanageable. It was not a one-time incident. It is part of my family member's life forever, but yet we didn't talk about it. And now value means several things based on where you are in that journey. And for Florida Blue, we have both Medicare plans as well as commercial plans. We're really looking at how we create value based on where that individual is in their journey. When we first looked at all of this and said, let's look at the data, because data tells us everything. Not really. Yes, we looked at all these 9 cohorts, people who didn't have any physical or mental diagnosis, a behavioral health diagnosis, to those that had some of the most complex physical and behavioral diagnosis. And what really came across as a common theme is they wanted access, and they wanted access that was meaningful to them. So being able to look at what those needs were enabling us to identify what was valuable to that individual and then begin to ensure that we were offering solutions and services that were going to meet them, whether they were just emerging and looking to manage stress and anxiety, resiliency, to those that were in those more complex cohorts who really needed a helping hand and guidance every step in their whole health journey. So you'll hear all of our executives at Florida Blue, really all of our employees, use the phrase that there is no health without mental health, because we now look at all of our individual members holistically through their whole health journey.
Great. Thank you both for that. Can we talk a little bit about if you think that mental health care should be defined differently than we think about medical, surgical care, how we can be better oriented, whole person, how do we think about paying, in a value-driven world? And then can we also talk about if there's models from the industry that we can really draft upon to think about how to build that in the behavioral health space? And maybe let me start with you, Samantha.
Yeah, absolutely. So first, integrated primary care. We've all heard the phrase, but what does that really mean? And what it comes down to is how are we helping those and empowering our primary care providers with actionable data to be able to treat that whole health? Regardless of who the provider is in the network, they don't have as robust a picture as we do as the payer about that individual patient. So we have been empowering our primary care providers with data through our provider portal and reporting that really embraces both the physical and the behavioral health results and outcomes. And I'm proud to say that at this point, all of our primary care medical adult provider value-based arrangements include at least one behavioral health quality metric. So, where the money goes oftentimes drives action. So by having those behavioral health quality metrics in their value-based arrangements, they are fully in to looking at the whole health. But equally important is being able to say, okay, but let's focus also on specialized care. And it's interesting, as we went back and looked at some of our engagements and how that integration was happening, it was actually the oncology bundled payments that really first brought to the forefront the idea of having a behavioral health specialist in their practice, because they knew the importance of addressing mental well-being for those individuals who were in cancer treatment. So we were late in embracing with them how we integrated that into their value-based arrangements, but not anymore. So we're now focusing on OBGYN value-based arrangements and pediatric value-based arrangements so that we can really make sure that we're creating that balance across all of the medical practices. And then with Lucet and the way in which they are enabling us through their technology to have an assessment at the point that a member is saying, hey, schedule an appointment with a therapist for me, we're able to start creating baseline data, and then the subsequent assessment after they've been receiving therapy tells us the impact. That's the value that's going to lead into value-based arrangements with behavioral health providers.
Thank you. I'm going to focus on Medicare Advantage. And I do think today there is already a focus in the space around mental health and behavioral health, in kind of two ways with Medicare Advantage. So the way that Medicare Advantage payers are compensated is through CMS's evaluation of our ability to provide quality care to seniors. And this is measured in a number of different factors. There's operational and administrative factors, such as how long it takes for a member who's in a foreign language for us to pick up their phone call. But then there's also quality measures. And within those buckets of quality measures, there are specific behavioral health outcome metrics that we are rated upon. And some of them include, you've probably heard FA30, so follow up to a mental health admission within 30 days. You've probably heard of AMM, right? It's medication management. You've also probably heard of inpatient admissions per thousand, inpatient readmissions. These are all metrics that we're measured upon by CMS to determine how high of a quality we're providing care to our members. And the higher quality, the more we get paid. So I think there are outcome metrics already in place, and that's one thing that CMS focuses on. The second piece, though, is you can't get to these outcomes if you don't have access to the doctors. And we talk about this a lot, it's a buzzword. And so some of the shifts in the industry that Medicare is trying to apply is ensuring that there's regulations around the access. So as of today, we are monitored and we are regulated around the amount of psychiatrists and inpatient psych that we have contracted in our network. But as we all know, there's a lot of folks who want psychologists, MFTs, right, MHCs. And so we're seeing that dynamic shift in which next year they are rolling out a regulation where there's actually going to be network adequacy and access requirements around psychologists as well, and clinical social workers. And just a few days ago, they came out with a 2025 proposal around requiring this for MFTs and MHCs for 2025. So through these regulations, it's shifting the MA industry to say, we have to ensure the right type of providers are in place, the access is there, and then we're also going to monitor actual outcomes in this area. I just want to add, though, because I know today, part of the session is around obstacles to value-based care, so I do want to touch upon some of the obstacles we face in this area. SCAN's largely been a California health plan. We just launched in our new states just a couple years ago. But if folks don't realize, California's been doing value-based care for decades. And what does that mean? It means we have a large number of medical groups that come together, bring PCP, specialist hospitals, ancillaries together that are all incentivized in a way so that they're all managing the cost of a member together. That's what I view as value-based care. And what that means is more preventative care, right? Keeping those patients out of high-cost procedures, high-cost hospitalizations, admissions. But outside of California, that's rare. And so that's something that we're building at SCAN. And even in California, where we've been doing this for 4 decades, we have medical groups who struggle to have behavioral health providers in their network. And so in those cases, we have about 10,000 members. That's where what we call SCAN takes the behavioral health risk. And that's where we look for a partner to say, how can we provide better behavioral health access and care to these 10,000 members where SCAN is owning the behavioral health risk? And that's where Lucet comes in. And I'll share a little bit more later about why we selected Lucet and what really stood out when we did that RFP.
Great. Thank you both for that. So I'm sure we have a lot of technology vendors in the room. I'm sure they have mixed opinions on whether payers are great partners from a technology perspective. Can you talk a little bit about the role of technology and, particularly how the Behavioral Health Information Technology Now Act might be akin to, what we saw with the High Tech Act and sort of the adoption of technology? And Wendy, I'll start with you on that one. But Samantha, whoever wants to jump in.
Yeah, I think kind of springboarding on what Wendy said, Florida is a market that is not predominantly large health systems. And so that does create some of the challenges with this work, in addition to the technology adoption. Because a large health system is investing across the entire system. Florida Blue is a strong proponent for independent provider practices. And particularly in behavioral health, that is the common structure in which for decades, those behavioral health specialists operated as a small business, really being very personable with their patients, not having a large office staff because they didn't need it. It was about that one-on-one engagement with their patients. So one of the things that we experienced a few years ago was this idea of all this great new technology, but hey, Mr. Provider, there's gonna be a fee for you to use this technology so that we can help you. Oh, and probably is going to affect your administrative expenses too, oversight. So we needed to look for ways that we could bring technology to our provider partners that wasn't going to cost them anything extra, and better yet, actually optimize their practice to improve their revenue and their own personal profitability. So I'm going to jump ahead to say that Lucet was part of the partnership in that with the technology that they have, by providers willing to engage in this platform, Lucet is able to schedule appointments on behalf of that provider. So they can really focus on being in the session with the patient. It also enables them to fill up their calendar so that they really are optimizing their practice. But equally important, as I'd mentioned earlier, is that initial assessment and then the follow-up assessment. Now we have data that says you received this patient with this score, and 6-8 weeks or at the designated time, look at the improvement you've made. What a great way to demonstrate appreciation of that individual provider. Now, on the member side, it's a little bit different. When would you ever thought of, I'm going to go to my insurance company for digital solutions? Don't they just pay my claims? Isn't that what their job is? Well, it really isn't. And here at Florida Blue, we talk often about we are more than just an insurance company, we are a health solutions company. So we are really bringing those digital solutions to the forefront for our members, bringing them in through our front digital door, and then serving up these solutions. In fact, we're using algorithms to identify our members who would benefit from some of these solutions. For example, we use Mequilibrium as a resiliency mental well-being digital application. And so through members who are identified, as soon as they log on to the Florida Blue member website, they are actually presented as a pop-up information about that solution. We're also doing the same thing for Lucet's appointment scheduling. So if we've seen that you've had, a diagnosis, but you haven't recently had a visit for your behavioral health diagnosis, we're going to pop up a message that says, hey, we've got this great opportunity to help you schedule an appointment. Let's get you connected with Lucet. So it's about meeting them where they're at, and if they're in your digital front door or app in their hand, then we need to take advantage of that. And then they start to expand and use all the other solutions.
I agree with a lot of what you just said. But again, just focusing more on how we think about support for a segment of the population, right? Older adults. They've felt stigma, throughout their generational upbringing around behavioral health. They may not be used to technology. They like to pick up the phone and call and make appointments. So when we were evaluating, new partners for the 10,000 lives where SCAN is owning the behavioral health experience for our members, we looked for a few things, and I'll highlight the areas that you really leverage technology with Lucet. As mentioned, right, I think we all understand, doesn't matter what age you are, every single human has moments where they realize, I need mental health support, whether it's mild, medium, serious. It's just for seniors, right? That triggering moment could be a bit different. Could be a loss of a spouse, a child, feeling a loss of purpose, loss of mobility, independence. And so we need to understand that and recognize that and create programs that, kind of support the journey that our seniors are going through. And so when we selected Lucet, one of the areas that really stood out is their ability to proactively identify and engage with our members, right? Think about back to the story about my grandfather. He had a lot of stigma growing up. He didn't even really understand what is mental health, what does it mean. He was never diagnosed, never saw a therapist. I think if he did, that it would have been a very different, story. And so what we have structured between our partnership at SCAN with Lucet is we actually will share our members in the program's medical and pharmacy claims and the behavioral health responses to the health risk assessment that every member has to do every year. And what we use that data to do is run it through an algorithm. So if we see a member hasn't actually had a behavioral health service or appointment with Lucet yet, but has a medical diagnosis for a behavioral health condition, is on a medication through the pharmacy claims for a behavioral health need, or responds anxious, depressed on an HRA, we can get that list and we can proactively identify and outreach and kind of take that onus off the member, take that stigma out of the equation and help proactively give them that support rather than it being reactive. So that's one area where we think that technology and data enablement has really created something unique here. The second piece, which Samantha talked about, is right, we also want to take the onus off the member to have to find that therapist. Our previous partner, what would happen is first a member would have to self-identify, I'm anxious, I'm depressed, I need help. They're then referred to an online directory. They call. Therapist has a 3-month wait time, 3-hour drive. They end up seeing the therapist 3 months later. The therapist is mean. It wasn't somebody that really fit for what they needed. So what we really liked when we were exploring options last year is that Lucet will have our member, when they need the support, screen them while they're on the phone and ask them while they're on the phone to say, what type of therapy would you like if you have a preference? Vietnamese, CBT, Asian therapist in a zip code 5 miles away? Great. The Navigate and Connect platform is the back-end technology scheduling platform that Lucet provides so that when a member's on the phone in that 5-minute phone call, they can be directly scheduled. Whereas today with some of our other partners, we have no idea. They call and they drop off, and we just see low utilization, but we have no idea what happened. So again, we're really excited to expand our partnership and really test this with Lucet. And I want to add, kind of as we're getting that preference, right, as the member's on the phone, that's really valuable real-time data. And I think we all know there is a lack of behavioral health providers. There just is. And a lot of them only want cash pay because it's an admin burden to, bill their CPT codes with Medicare Advantage. So there just isn't enough. And so what I also like about this platform is as we're collecting these appointment requests and preferences, we can be smart about how we design the network. Right? We're not just going out and saying, okay, we're just going to meet CMS network adequacy minimum and get these psychiatrists. We need 8 in this county to meet the requirement. It's no. We have members asking for a specific type of MFT, of a gender, of a race. And then we can go out and curate that network with Lucet if we find out, oh gosh, we don't really have that person or it's a long wait time to have a member see this type of therapist that they're looking for. So those are just a few of the examples where I think technology can be leveraged, even in an older adult population. And I'm just going to go back to, again, kind of the obstacles, though, that we face. It's tough, right? Because the member's a part of a primary care in a medical group. The medical group maybe doesn't understand the network and the access that we're building. So it's on us at SCAN and Lucet to really integrate our programs with the medical group, with the PCPs, make sure they understand, right, there is access. Don't be afraid to refer. This is how you can refer. It can be secure email, it can be through a phone call, it can be through a portal. Let's make it easy for our providers to take out the roadblocks and the bottlenecks that are, we use this buzzword, but access. It's a huge issue today.
Yeah, I love how you both talked about, when we talked about technology, sort of the ecosystem and intersection, right? Like, I do think this comes back to people, process, technology, and sort of the partnership and embedding this into workflows, right? Technology in isolation, like, there are probably, phenomenal solutions in the room. It's how does it integrate into the workflows? How do we figure out all the collaboration that has to happen? And I feel like that's where the unlock happens, right? And I think, your organizations have been really great on that, both with us, but with also other solution partners where you've led on that. I guess on the topic of collaboration, can we talk a little bit about how payers, employers, providers can acknowledge and jointly tackle some of these roadblocks? I know, Wendy, you've started to touch on that and overcome them, whether it's patient attribution, EMR adoption, system interoperability, right? Like, the list can go on here. And so can you both speak on that topic?
Sure, I'll start. It's tough, right?
Yeah.
Because healthcare is so fragmented, it's so disparate, right? You've got your patient, you've got pharmacy, you've got the medical group, your primary care might be at a different health system or practice than your specialist. None of the systems speak to each other, no one's coordinated. And so we strive to do our best in building that interconnectivity. And so one of the things that we've done with the Lucet program, as we've implemented this with our partnering medical groups, is we try to be very proactive and think upstream when it comes to implementation. So one of the, I think really kind of great things that we're doing is before we even go live, we come together between SCAN, the medical group, and Lucet, and we review a long list of ICD-10, CPT, HCPCS codes, and we say, okay, is this medical or is this behavioral health? Because there's a lot of gray areas. And if this is higher acuity care, are we going to require a referral or an auth or not? Because this then allows us to prevent our seniors down the road when they're trying to access care get punted back and forth. Well, I'm not paying this claim, you're paying this claim. And so we try to do a lot of that integration and that operational kind of implementation earlier to avoid those downstream issues. And again, with the focus of providing better care to our seniors, keeping them healthy and independent, and ultimately, trying to reduce overall medical costs.
Yeah, and I think that's the important point, Wendy, that you mentioned. It's about having actionable data and easily, readily usable data. When we think, again, as I'd mentioned previously, an insurance company, how are they going to help me? But really, it's about leveraging trusted partners. So first with the providers, giving them actionable information, but they don't have time to craft emails that they're going to send out to their patients. They don't have time to figure out, okay, out of all of my patients, which ones are Florida Blue and which ones are those other insurance plans? So how am I going to get this message you gave me, Florida Blue, to just your Florida Blue patients? So that's part of working and pre-planning with our providers, empowering them with information that is as simple as, and here's the list that you'll want to send to. These are your patients that apply to this solution. Here's a draft email we would recommend that you would send out to your patients, because if a provider says to do it, more likely that individual is going to do it, not coming from the insurance company. So in a similar way, we've approached our employers to do that too, because they're overwhelmed with all of their HR duties to inform and educate their employees. So we bring to them information that through some of our solutions, we're able to highlight. Do you know that 20% of your population have self-identified as depressed? Do you know that 50% of your members are of your employees are struggling with financial concerns? So we're able to look at the data that, again, as a repository of a variety of information, bring it back to that employer and give them information that can be an email blast. It could be specialized training where here's the individuals we'd recommend you invite without, breaching confidentiality. And we even give them simple things like, hey, at the end of your staff meeting, slide this into your PowerPoint, and it'll promote the Lucet appointment scheduling. It'll promote call Florida Blue for your physical needs, both your physical and your mental health needs, so that we're really making it part of the way they communicate with their employees, but in an easy way and targeted way. So those trusted partners are really how we overcome these obstacles. Is it perfect? No, it's never perfect. But we are getting better and better at it, and it's that constant feedback loop that is making the difference.
That's great. I think we're going to hear value-based care as a buzzword, right? You can't have that conversation without talking about the obstacles that you sort of need to get through. I think you guys have laid out a lot of the infrastructure that has to be in place, the data, all the pieces that have to be true before you can get to that. But can you talk a little bit about which domino needs to fall first, and how do you think we unlock that shift to value, and where we've made progress and where maybe we haven't? We want the optimist or the pessimist first? No, I'm just kidding.
Well, I'm going to jump in first and say, really, I think one of the first dominoes have already fallen. I want you to think back pre-pandemic. How many commercials did you see about mental health or mental well-being? How many do you see now? What a shift in the national conversation. You could not have anticipated that shift pre-pandemic, but the pandemic brought it to everyone's attention. Now, has that completely eliminated the obstacles to having those conversations or finding solutions? No. But the mere fact that it's now in the ether of our communities and our conversations means that it's opening the door to the ideas there is no health without mental health. And then you can start introducing solutions and services as part of that conversation. Because, and I'm going to steal from a gentleman who I went to a previous presentation, if you were to say, hey, are you hungry? And the answer was, yes, I'm hungry. And you go, oh, sorry to hear that. Well, if you're screening someone for behavioral health, mental health, substance use, and you say, oh, sorry to hear that, and you do nothing else, it's really not effective. So we've got to be able to have the conversation, but have intentional solutions to put in the hands and to help serve those individuals.
Guess I'm the other side of the coin a bit. I completely agree. The focus on mental health has absolutely increased since the pandemic, right? I think I even went through my own sort of mental health, experience through the pandemic when you're isolated and lonely, right? So I agree, there's a greater focus, but if we think about value-based care, not just using a buzzword, but what does it actually mean? It means participating in a way where you are getting compensated based on outcomes, not transactional volume fee for service. I don't know if the domino has fallen. I don't, right? When you, and even outside of behavioral health, think about your cardiologists, hospitals, specialists. They're really volume-based. And it's really hard to get these entities and these individuals to understand, hey, you can get compensated equally, if not more, based on outcomes. But as Samantha talked about, right, that requires years of data, processes, systems, understanding how to manage costs, understanding how to monitor that, right? And I just don't know if we're quite there yet, especially in the behavioral health space. We're at a point where many therapists, again, they're still cash pay because it's easier and, they can charge more. They don't have to bill Medicare. And so how do we get them into this fold where they truly can get paid off of improvements in inpatient readmissions, right? Or the FA30s or antidepressant medication management. I don't know if we've quite cracked the way to incentivize that in our contracts. Again, in California, right, where we have about 300,000 members, there are certain groups that have fully employed behavioral health specialists. They're fully integrated. They do collaborative care. We actually are launching with a new medical group here in Maricopa County, Evernorth, and they've started to hire their own clinical social workers and do collaborative care with their PCPs. So there certainly is starting, we're starting to see that shift slowly, but I don't know if the full domino has fallen yet.
Yeah, it's interesting. I mean, we know that BH is a force multiplier on many of these conditions where we now see this crop of different companies taking on full cap risk, right, for these different conditions, whether it's cardiac, whether it's kidney, and all these areas. So I think it'll be interesting to see sort of how that plays out, because in theory, the bones are there for us to get to value. I guess on that point, how are you thinking from that integrated perspective and BH being sort of at the intersection on the health plan side for these different conditions? Are you delegating risk based on the condition? How does BH kind of fit into that? And maybe if you guys can speak to that.
Sure. Well, I think SCAN is, again, a bit unique, being mostly a historical California plan, but we're growing. We're going into other markets that aren't used to, this type of delegation like California. But in California, it's interesting. We see kind of a spectrum, right? There's certain groups that have the full, network of behavioral health providers, and they take the full risk, and SCAN really isn't involved. But then we have other groups that don't have that, and we take all the risk and subdelegate that to Lucet. Or there's components, let's say they are comfortable with inpatient psych, but not outpatient professional. And that's where we'll partner in curating a targeted network to support that specific network that is needed for those members. But there's different flavors of it. And again, I just want to circle back to the bigger picture of, BH, like primary care, it's kind of at the center of all of this, right? If we're not mentally well, we're not physically well. So whatever we can do to integrate and think about the bigger picture and incorporate BH, we should be, but it's not easy.
Yeah, and as I'd mentioned previously, we really started our journey in integrating behavioral health in value-based arrangements with the medical provider, primary care providers, our specialists, the oncologists, the gynecologists, those practices. But it's just the beginning. Adding 1 or 2 behavioral health quality metrics is not going to solve all of the needs. So it will be an evolving model. I would add, though, what's interesting is how we're looking at how we can do this at the behavioral health practice level. Because, as I mentioned, in Florida, we have a few large health systems, but not the entire state blanketed with that. So it's important at looking at how we can bring the behavioral health provider to the table, and that's where the new and emerging information is really coming about. And we'll have to see how that evolves in the next couple of years.
That's great. So we have about 9 minutes left. I'm going to turn it over to our audience because I know we have such great representation from so many different segments in behavioral health to see if there are questions from the audience. And is there someone, mic running or no? All right. Well, we'll have you come up to the front and then I can. Oh, you want to? Okay. You can mic run since hopefully I'm not answering questions. Thanks, Lexi. Yeah, of course. Anyone?
My skirt makes a lot of noise, sorry. Thank you so much for your insight. Can you speak a little bit more about where you think some of the friction is? Do you think it's the health plans really wanting to enter into value-based arrangements, sort of versus providers' willingness to do that? Can you talk a little bit about in the ecosystem of the provider and payer relationship, where you see the friction?
Yeah, and I'll focus specifically on the idea that they need the data to be empowered. So while I can proudly say that 100% of our adult accountable care organizations have a behavioral health quality metric, it hasn't been easy, and there's still some pushback. As they adopt the antidepressant medication or follow up after inpatient mental health, they're like, but I don't get the information soon enough. You got to get it to me sooner. And I think that's where the friction is. The provider saying, you're going to hold me accountable, but you have the information. So how are we going to bridge that so that we have the information and the patient is benefiting? So I think that's where the friction is coming from, but it continues to get better, and I certainly see it evolving even more.
Yeah, I think the other friction point is the money, right? I never thought I'd work for a payer, and here I am at SCAN. And what draws me to SCAN is we are a not-for-profit, so we don't need to take that 5% margin and give it to shareholders and, go to Wall Street. We reinvest in our provider partnerships, compensating fairly, reinvesting into benefits to our members. But I think a lot of it is financial. In California, where health plans and medical groups, IPAs, we've been doing this for decades, and so it's very common that medical groups are taking the behavioral health risk and building these networks. But outside of California, as I've taken on the role managing Arizona, Nevada, and Texas, it's very, very limited, where groups are sophisticated enough, they've built these networks, they've really integrated it. But what's really interesting is as I've talked to these new groups about SCAN and kind of our value prop, their ears perk up when they say, wait, you want to go on this journey with me and share data with me so that over the years we can progress to taking on full risk and delegation? Wow. Other payers don't offer that to me because they get to keep more of the dollars. But SCAN is unique. We want to progress the industry towards true value-based care. And if it means giving up most of our dollars to get more integrated care for our members, we want to do that.
I have have $1,000,000 question for you for these payers. And I work for one myself. What is the setback by integrating full behavioral health services with the payers? Why are we delivering mental health, full-blown mental health? So like, why is Blue Cross Blue Shield not delivering that mental health directly? You know, like hiring on board the psychoanalyst practitioners, the psychiatrists, and having us take care of the patients directly from the health plan. What is the setback? What is the fear? What is holding us back?
Well, and I want to make sure I understand the question clearly. Is it really at the core of your question, why are we delegating
Yes.
the oversight to a partner like Lucet? It really comes to the idea that they are specializing in something, and we do this with other specialties. It's not just behavioral health. So we have care partners, that's what we call them at Florida Blue, is care partners, who have invested in technology, services, and the expertise that we really can't be at the payer everything to everyone. So having a partner like Lucet, we know they're investing in understanding the needs, staying ahead of the curve, and we're simply being able to leverage that expertise to deliver that. But you're right, we don't want the member to feel like it's a disjointed experience. We don't want the provider to feel like it's a disjointed experience. So that's why with a lot of the work that we're doing with the medical providers, we are ensuring that they understand the role of Lucet and how it really is a partnership. What's fabulous is Lucet actually offers for our providers in Florida a hotline. So a medical provider can call Lucet and say, hey, I've got this patient, I was giving her, antidepressant medication, but other things are starting to occur, and I'm not quite sure how to add more or possibly reduce what's in the care plan for the best outcome. And their behavioral health clinicians can have that conversation with that medical clinician. So it's that sort of partnership that is intended to avoid the disjointed experience and drive the best outcomes.
I'll speak for SCAN. I think we would love to build our own network of psychologists, psychiatrists, inpatient, right? We've been limited, again, because we've been so California regional, in that California is accustomed to the payer delegating everything. So that's even PCPs, hospitals, right? We delegate credentialing, claims, CM, behavioral health or not. And so part of the journey that we're going on at SCAN is we recognize, gosh, that doesn't work outside of California. And so we've been on this journey of building our own capabilities of doing credentialing, claims, CM at scale. But it takes time, right? And it takes, I don't know how many RFPs we've done this year for new vendors, right? But ultimately, we'd like to get there. I think part of our hurdle has really just been our history of the region we've been in and not having that sort of operational infrastructure to do so yet.
Yeah, and if I can just briefly comment there, I mean, I do think in some ways sort of in-source, outsource is like the wrong false dichotomy. I think, we fundamentally believe it's around looking at how are you going to drive as much behavioral health care as possible for that member, and what are going to be the ways to do that, and how do you redraw the lines to say, hey, there's things that Florida Blue, SCAN, or other health plans are phenomenally good at for their members. However, at scale, we see all day, every day, behavioral health, we're looking at supply and demand matching. We're seeing how do you get that person with a particular set of characteristics to connect into care, and doing that at scale has real power. 10 to 15% of people screen positive in the moment to need a clinician. I think we already have a clinician shortage, right? Trying to have every health plan in the country sort of staff up to service those 10 to 15%. And frankly, the more you drive behavioral health and push it, the more people are going to be in that category, right? And so I think, we don't see black and white lines there. We see a very, sort of the wheel that we look at together to say, hey, what are the pieces that you feel like you're really exceptionally good at, whether that's member engagement, whatever those things are, and how do we add on for the BH component of that, which then ultimately drives to the best solution. So, I think people get really hung up on the sort of in-source, outsource, bad, good. I think it's, we think about the world a little bit differently than that.
Hi, right over here. They're living over there. Anyway, I'm right here.
Hi.
I'm short and I'm sitting down, so
I know, I heard the voice from
disappear.
over there.
So speaking of clinician shortage, I'm a CEO of a behavioral health company, but I'm also a psychologist. And one of the huge challenges that's sensitive to me is that when we try to recruit clinicians, especially let's say an LCSW, and we say this is a clinical role, and we give them a salary, and they're like, oh, well, if I work for a healthcare plan, just reviewing charts, I can make 30% more. So what are healthcare plans or people in positions like you doing to make sure that that doesn't continue? Because that is a significant barrier for recruitment, especially at the master's level clinicians. Well, it really is only at level clinicians that it's literally could be, at least in Arizona for sure, a clinical position could be $85,000, and if they work for Optum reviewing charts, it could be minimum 120, something like that. I know you're making faces, but I mean, what do you guys think of this? This has been my experience.
I made a face when you said Optum. That's why.
Yeah, and ironically, if that is, I don't know if those individuals impacted that would use that word ironically, that's not just for the licensed clinical social workers. It happens with pharmacists, and it happens with a lot of specialized providers. So that's where getting back to this idea of a value-based arrangement is that you're really compensating that practice for their overall outcomes, and they're sharing in the reduction of total medical expense. Now, how they split that shared savings, I cannot say, but it really does allow them to pay higher for all of their support staff or direct clinicians than a traditional fee-for-service. Because if you're following the Medicare rates, they just keep going down and down and down, and that is not the direction we want to go to demonstrate value for those services. So it's helping engage and shift to value-based that will drive the increase based on the impact that that clinician makes.
Sorry, I'm going to go really quick because they're telling us to stop. I don't think we do that at SCAN. I don't think we pay more just to do chart reviews. We do have a few clinicians. I'm looking at our new BH leader here. She has a psychology. She has a PhD in psychology. But we compensate fairly, even as a nonprofit. And what we do is, for example, we have a behavioral health clinician who supports our Embrace product. It's a product where our members are in assisted living facilities, institutional special needs plan, and she actually goes into these facilities and helps integrate, the behavioral health, care that we're providing, whether it's through Lucet or through her, through the staff that's at the ALF. And so that, I think, goes above and beyond maybe what a typical clinician in BH would do, and she's compensated. I don't know what she gets paid, but I think she gets paid pretty fairly for that.
All right, well, thank you, Sam. Thank you, Wendy, for a really, really engaging panel, and thank you all for listening.